911 emergency. First unit accident.
Nothing is ever written in stone. Darling, oh, I am coming home.
911 emergency. First year accident.
Nothing is ever written in stone. Darling, oh, I am coming home.
Hi, everyone. Good morning. Welcome to this session where I'll be interviewing Susanna Lobo, Marlies Osterman, and Massimo Antonelli, who is unfortunately joining us digitally today. And I will interview you about the sessions that you had earlier this conference. And Susanna, I'd like to ask you first, what's the key message from the talk you did on fluids that you would like the listeners to hear?
Thank you for your answer, your question, sorry. I think the main message was to individualize fluids. And then we talked a lot about 3 steps. First, just give fluids for those who really need fluids. Then first, look at the necessity. Second, evaluate fluid responsiveness. It means, will patient improve cardiac output with fluids? And third, even before giving fluids, look at it will not cause harm. And very importantly, we should individualize. There are no 2 patients alike, and if you give too little, it can harm. If you give too much, it also can harm. Then we should individualize and give the right amount.
All right, so that's a very clear message. Individualize your fluid therapy, make sure it doesn't do harm, evaluate whether the patient needs it. That's a very clear message. I think Massimo, I can't see you yet, but are you there? There you are.
Morning.
Good to
Good
see
morning.
you. Massimo,
Thank you.
You presented on the use of non-invasive ventilation. What's the key message you want the people here to hear about that?
I guess that the individualization is the leitmotif of the present approach to patients. However, for what concerns the non-invasive ventilation, there is no exception. The pandemic has changed the picture in the sense that due to the surge of the COVID-19 and the bed constraint into the ICU or the lack of availability of the mechanical ventilators, there was a revamp of the non-invasive ventilation in general. But 2 different techniques have been largely applied during these days. And one is the very well-known high-flow oxygen therapy that can be considered somehow a form of non-invasive ventilation capable also to deliver a small amount of PEEP and achieving several beneficial effects, including the expansion of the end expiratory lung volume, a better comfort, and a better washout of CO2. And as it was in the real life during these days, largely applied also in prone positioning, achieving good results. In the other, I would say novelty, but indeed is something that has been introduced into the clinical use, at least in Italy, since the early 2000s, is the helmet. And the helmet used both as a way to deliver CPAP as a free flow or as a way, as a interface to deliver non-invasive ventilation in forms of support, pressure support. And in this case, you need to keep in mind some settings, specific settings. We perform a randomized trial comparing these 2 techniques, and they were both usable and I would say effective in the early phases of the acute RDS. However, if you want to compare the secondary outcomes in terms of endotracheal intubations, the patients who received the helmet had indeed a benefit, reducing the number of intubations in comparison to the high-flow oxygen therapy. But both of the real message is you can use them safely, provided the fact that you have predefined criteria for the intubation and deterioration. And this may represent an option for avoiding further deterioration of the patient.
Thanks, Massimo. That's a very clear message. And also, like Susanna, you are stressing that we have to individualize the therapy, kind of taking into account the evidence. As a last participant in this interview, I'll now ask you, Marlies, to give us the main message of your presentation on renal replacement therapy. What do you think the most important thing is?
Thank you, Lenny. So my talk focused on timing of renal replacement therapy. And that's obviously an important issue because we deliver renal replacement therapy to 10 to 15% of our patients. So we routinely start renal replacement therapy. My three key messages in the talk were, number one, the recent 5 landmark trials have given us confidence that it is safe to wait with the initiation of renal replacement therapy unless there are absolute indications. The second message is that the studies have confirmed that the initiation should not be based on creatinine alone or acute kidney injury stage. And the third message is that despite these 5 landmark trials, we still have uncertainty when deciding the timing of renal replacement therapy in the individual patient in front of us. And that is because there are so many other factors that come into play when deciding whether to start. So for instance, fluid balance, degree of acidity, acidosis, and so forth. And these were factors that were not included in the landmark trials, but obviously play an important role in clinical practice. So for the clinician at the bedside, the decision when to start renal replacement therapy, so not too early, but also not too late when it may be too late, remains challenging, and we need more education and more research in this area.
So I think this is really interesting because all three of you, though you're talking about different fields, you say like not too much, not too little, not too early, not too late, and also Massimo said we have to individualize the therapy to the patient. So then, Susanna, I'm going to ask you first. There's lots of research on fluids, and it's very hard to kind of distill a message for the clinician at the bedside. Kind of, how do you think we should go forward? What are the big questions? Where do we go with the, collecting the evidence, understanding when we are giving too little or too much? What do you think the path forward is?
I think we have a lot of ways to give fluids, and the important is to do it in a safe manner. So we have to monitor. And for high-risk surgeries, we were talking about perioperative patients, or even in the ICU or other septic patients. As long as the patient has circulatory failure or signs of hypovolemia, we should monitor. And I think we had a lot of advanced breakthroughs in the last few years.
What's the biggest breakthrough, you think?
I think the way we are working now with cardiac output monitoring even more frequently, more safety, we know how to use it. I think the problem is the poor adoption in some places, low resource settings, because we have much more than the type of fluid or the go direct therapy, the strategy we are using. Then as we see a lot of good strategies that are leading for better outcomes in perioperative patients. And we can see that the mortality is decreasing.
Right, so what you're saying is, especially the fact that we can monitor better what is too much and what is too little, that's the advancement that's important now.
Yeah, I think it is.
Massimo, for you I have a different question, because you elegantly described the use of NIV, Optiflow, or high-flow nasal oxygen and the helmet. What do you think the biggest misconception is that clinicians have about non-invasive ventilation?
I would say there are 2 misconceptions. One is in favor of the techniques, and at times when people fall in love with this technique, may insist too much in very severe patients, also because they see a slight improvement in gas changes, but indeed they still remain tachypneic, dyspneic, with other oxygenation or problems. Indeed, we saw so many times arriving in my ICU during these days, the patients who were put on continuously on non-invasive ventilation with a helmet, for example, for, let's say, 10 days, which is absolutely wrong because it means that the patient had no real improvement over time. And this is the misconception that at times may cause harm, and we need to be very careful. On the other hand, there is the, let's say, the prejudice coming from the what I call the puristic of the mechanical ventilation, where those patients who are on LDS should never put on invasive ventilation and should never have a sort of coverage with the spontaneous breathing, because it causes an excessive inspiratory swing, an excessive work of breathing, and may cause what is called the self-induced lung injury. But against this interpretation is the fact that as soon as you apply the pressure support to these patients, you may see that the work of breathing may be reduced, and also the tidal volumes regularize, let's say. With even though we may get, when used pressure support, some small increase of transpulmonary pressure, nonetheless, this may also correspond to less work of breathing on the patient at lower tidal volumes. Those who are less severe probably do not have such a big advantage. However, in general, we have to consider that we need to have always to identify the best patients to be targeted. One possibility should be the use of the esophageal catheter, which offers a surrogate of the pleural pressure and can allow us to measure the transpulmonary pressure. Under this condition, and showing if the inspiratory swing of the patient is excessive even after the application of non-invasive ventilation, may be a tool for better driving the application of the technique. Is this applicable anytime, anyway? I'm not sure about that on the everyday clinical life.
Thanks, Massimo, and I may come back to you about some of the things you said, but first I want to go to Marlies. So Marlies, we've talked about individualization, that's a very difficult word, sorry, and you talked about timing of renal replacement therapy. So what do you think about individualization of renal replacement therapy in the ICU? Is that a path we should focus on? Do we need to do much more tailoring, or what's your opinion?
Of course, that's what we try to do. We aim to individualize renal replacement therapy with regards to timing, dose, discontinuation, modality, all these aspects. But that's the aim, and clearly we need more research in this area and also more education to make this possible, so that patients receive renal replacement therapy in a timely fashion. What is early for one patient may actually be too late for somebody else. And with these recent 5 landmark trials, we have actually gained a huge amount of information. Now, we've also revealed gaps in our knowledge and new uncertainties, but that's great, because we can now analyze these data and identify those patients who benefited from initiation of renal replacement therapy maybe a little bit earlier than others. And we can hopefully identify those factors that play the most important role and have the biggest impact on mortality. Because we don't want to start too early, where patients then may end up remaining dialysis dependent for life, as it was shown in the START AKI trial. And at the same time, we don't want to increase the risk of dying by delaying it for too long, which was also shown in the most recent AKIKI 2 trial. But the balance between the two, it will depend on the individual patient comorbidities. And that's where we urgently need to learn more, so that we find these factors that trigger the potential need for renal replacement therapy in an individual patient.
And Marlies, where do you think the biggest gaps are after these 5 landmark trials? Are they in the timing, or are they in the indication, or in kind of the amount of renal replacement therapy that we give, or the method? Where are the biggest gaps, you think?
I think there's a big gap related to timing, but the biggest gap overriding the whole problem, in my opinion, is the fact that our tools to monitor kidney function at the bedside are very, very limited. So we realistically only have creatinine, we may use urea, we may use urine output. But all 3 factors are confounded by other illnesses and are not renal specific. And we have little tools outside the research agenda to describe kidney health. Do we really know whether a kidney is recovering or not? If we just monitor the creatinine, and I put it to you, no, the creatinine is insufficient for this scenario. Yeah. So if we had better tools to describe kidney health, which means the kidney function that's getting worse, but also a kidney that is recovering from acute kidney injury, then we would have better tools to apply the therapies which are available to us.
Yeah, I think that's a very clear message, that that's where the gap is in the diagnostics, or one of the gaps at least. I want to go back to Massimo first. Massimo, you were talking about esophageal measurements for non-invasive ventilation. So I have 2 questions. The first is, so how would you in practice do that in a non-invasively ventilated patient? Like, how long would you measure? What would be the most important measurements for you to guide your therapy on? And the second thing is, because this is quite novel to do this as standard of care, these type of measurements, kind of what in non-invasive ventilation do you think has changed most in the last, let's say, 10 years?
Well, the use of the esophageal catheter can offer the possibility mostly of measuring the transpulmonary pressure, which is the difference between the alveolar pressure induced by the mechanical ventilator, the support of pressure that we deliver to the patient, and the pressure that is inside the pleural space. For example, if we do have 15 centimeters of water of pressure support, and we have minus 10 centimeters of water into the pleural pressure, the transpulmonary pressure will be plus 25 for mathematical reasons. And so the way in which we can monitor repeating, I couldn't say constantly, but often, these measurements may help in just targeting the one of the potential harmful pressure for the lung, causing barotrauma and englobing together the mechanical power. It is out of question that all the other measurements that are conventionally used in RDS patients when they are intubated, and then invasive measurements, the application of inspiration hold or the expiration hold, the evaluation of compliance, are not possible in a spontaneously breathing patient. And then this may represent a limit, or at least it can be also done somehow, but obviously is more for research than for the usual care for everyday clinical life. So somehow we need to be a bit more clinical. But indeed, I would say that this kind of message is very common to the 3 of us, because despite the advanced monitoring we have, nonetheless, the clinical sense and the capability of having an accurate physical examination and a clinical thinking combined to the parameters that we can just have available is the right way. To answer the other question regarding what the non-invasive ventilation has changed over the last, let's say, 20 years, is certainly the improvement of the treatment of severe patients, mostly at the beginning, the COPD patients, and conditions like the cardiogenic pulmonary edema, even sparing the need of hospital admission, can be treated in the emergency, or for those patients who are already recovered, already admitted in the ward, can prevent the transfer into the ICU. And at the same time, can also assure a better comfort for those patients who indeed respond to the therapies. And ultimately, if you look at the mortality rate for severe patients who are treated successfully, you may immediately realize that in a large majority of the trials, the mortality rate of these patients who are successful is lower than the one that is achieved through the invasive ventilation. So a number of things that do not tell us to abandon the invasive ventilation, that remains the milestones, but offers new possibilities just for better treating and assuring a better comfort to our patients.
Thanks, Massimo. That was a really clear explanation of what the position of NIV is in their current practice. Susanna, so Massimo just described, actually the start of NIV in the last 20 years and how it's been more and more used and more patients have been benefiting from that. What do you think have been the biggest achievements in the last 10 years or so in how we use fluids in our everyday practice?
Yeah, just to remember, because I said the mortality is decreasing, the morbidity rate is still very high. And we have around 30% of moderate or major surgery patients having complications after surgery. And one complication has a very high cost. It's estimated around 15,000 euros. And I said in the last 20 years, especially in the last 5 years, we had the people had come with a lot of ways to estimate fluid necessity, fluid responsiveness, and even, for instance, the post-pressure variation, stroke volume variation, and even some ways to overcome the limitations of these methods. The monitoring of cardiac output is less and less invasive, and people are starting to use it. The real challenge would be make it more affordable, and because unfortunately the adoption is still poor. And then if a patient has an arterial line, a central venous line, we have a lot of things to do with this. And
all right. What you're saying, Susanna, is the biggest progress that we've made is the monitoring, not the fluids itself. Can you also reflect on what's changed in the use of fluids? Are we using more fluids than we did 10 years ago or less? We're using different types of fluids, and what's your opinion on that?
I think we have had many big studies, starting with the ones comparing balanced fluid solution with saline. And we see that there is actually no difference unless you give a lot of fluids. You have a hyperchloremia, and in this case, it's not good. But there are some indications, metabolic alkalosis, ketoacidosis. You still can use these solutions. But anyway, I think people are using more and more balanced solution because it is more important for surgeries of longer duration. About the quantity, liberal or restrictive, I think we were too liberal in the past, and they started to be more and more restrictive. And there is a very recent and large study showing that both can harm, because in the restrictive strategy, there were more acute kidney injury in these patients. So actually, for maintenance fluid, I think perioperative it would be in the middle, kind of moderately liberal, and with the excess fluid for fluid therapy, we should be use some kind of monitoring, even if it is not invasive, or like kind of CO2 gap or lactate or ETCO2, something that drive the fluid therapy.
So you already mentioned kidney injury, so that automatically then leads me to Marlies. If you talk about fluids, you talk about kidneys. I'm sure you have something to reflect on what was just said by Susanna, or the biggest developments in renal replacement therapy in the last 10, 15 years.
Undoubtedly, our understanding of acute kidney injury has advanced enormously. Our understanding of the complexity of renal replacement therapy has advanced. And with that in mind, I'm so pleased that the European Society of Intensive Care Medicine has increased the educational tools, because we all need to learn from each other to advance this field, so that we give the treatment to the patient who needs it without causing harm from either starting too early or too late, or giving the wrong thing. So we need to learn from each other. We need to do a bit more research. But the great thing is that we've had great educational tools. We've had master classes. We're all learning from each other. And I think that's been a fantastic advancement as far as I'm concerned.
Yeah, I think that's a very good thing to also say in this interview, because also on hemodynamic monitoring and on ventilation, there are masterclasses by ESICM that are very useful, and that have experts like you talking about the evidence and how to put it into practice.
We also learn from each other.
Yeah.
We learn from, sorry for interrupting, but I have learned in the masterclass, I am learning from the attendees who share their experience, and that's also an education learning experience for the people who do the courses, and that's fantastic.
Yeah, and you see what the practice variation is across Europe, and that's something to learn from. I was going to ask you something, but now I've completely... Right, Susanna said in fluids we're kind of less is more, right? We're using less and less. Is it the same for acute kidney injury? Are we using less and less renal replacement therapy? Are we less aggressive?
The trials, the 5 landmark trials, have shown us that it is safe to delay the initiation. Whether we're using less when we started, I am not sure yet. But we've learned that it is acceptable to delay and give a bit more time towards optimization of fluid status and hemodynamics, provided this occurs under regular monitoring and re-evaluation, because we don't want to just delay and then delay for too long when renal replacement therapy may actually be too late, and the risk of dying from complications of acute kidney injury is too high and outweighs any benefits. So any form of delay should always occur, or delaying under watchful waiting and re-evaluation.
And what should be the triggers to stop delaying?
That's a very good question. And again, that's where we need more, I think, help. So we understand when the kidney health is deteriorating to the point that the kidneys are no longer working adequately, and importantly, that the impact of acute kidney injury is detrimental to other organs. So we have to learn when fluid accumulation is harming the lungs, when the degree of acidosis is harming heart function, or when the accumulation of toxins is affecting the brain. So if the impact of acute kidney injury is making other organs worse, and kidney replacement could change this, then that would be the right time. Having said all this, this will be different for individual patients again. So we need to move away from early versus late. I think we have to focus on what are the triggers for the timely initiation in an individual patient with different comorbidities? And that's where we need to learn from these trials and from experience.
I think that's a very great statement to have before we go back to Massimo. So Massimo, I've already asked you, kind of looking back, what's changed the most. So now I'm going to ask you to look into the future. NIV, high-flow nasal oxygen, has developed a lot over the last 10 years. And as you already said, the COVID pandemic has also taught us lots and lots about non-invasive ventilation, just because we've had vast amounts of patients. Looking into the future, what do you think the most important developments are, things you're enthusiastic about now that you hope to see put into practice in 5 or 10 years?
Okay. May I make a comment, a preliminary comment, general comment? I guess that both Marlies and Susanna has stressed two very important points. At the times, as Marlies said, the capability of identifying the transition of a situation and the evolution toward the worsening is not easy at all. And it's a combination of factors that we have to take into account. And the same is true for what said Susanna. What we do at the bedside, in general, we don't have magic bullets or fantastic indicators. We put together different information. And this information, with a good clinical science, help us to take a decision. For what concerns your questions, I would say that the room for the development of non-invasive ventilation and this new form of oxygen therapy is relatively large. Of course, we shouldn't have any misunderstanding. In other words, should we apply the high-flow oxygen therapy as a form of delivering oxygen to any patient? You mean, for instance, after the surgical interventions, anytime, anywhere? The answer is obviously not. But for the patients who may be more severe or in certain situations, this may be certainly an option. As always, the matter is identifying the patients that have the best benefit. And the same is true for non-invasive ventilation. This is largely applied in various settings. For example, at the beginning of the story of the non-invasive ventilation, there was an extensive use into the immunocompromised setting, where patients who have, for instance, hematological malignancies may have serious complications, and even if they were intubated, this may expose them to further and more severe complications, namely ventilator-associated pneumonia. Despite the fact that the therapies and the approach to this patient pharmacologically also improved the most during the last 10 years, nonetheless, still having the possibility of sparing them a more invasive approach can be still an option. In other words, as always, we have to find out a balance. In the future, we may also apply in various settings, but always, as we said at the beginning, targeting to the right patient, the right moment, and with the right outcome. We need to have a clear mind, but with a careful and wise selection of the patient.
Thanks, Massimo. I think that's a picture that's emerging from all three of you, is that we're constantly trying to look for better ways to individualize therapy, because we know we are under-treating some patients, we're over-treating others, and we're trying to get the right treatment to the right patient at the right time. I think that's it's a bit of an open door, but that picture is emerging from all three of you. So Susanna, if I go back to you, what are you most enthusiastic about in terms of what we are researching in fluids, and kind of what do you think is important in the next 5 to 10 years? Can you give us a little bit of a look into the future of us handling fluids?
I think regarding to fluids, we have a lot of fluids. We should use all the fluids for different types of patients. We have different types of fluids, different moments. And I think the best, maybe what we should look for is the more cost-effective ways to monitor the patients, to give. But one very important thing for me is about organization, because we are talking about a lot. We have hundreds of big randomized control trials, testing this and testing that, and sometimes they didn't change outcomes. And sometimes we get some organization issues and better management, and then we have much better outcomes.
So
and
can you tell me what
lower
type of
harm.
organizational issues you're talking about? What type of...
For instance, to what you said, take care with the lower risk patients. What are they doing in the ICU? When I look at my results, I see that the standardized mortality rate in the very severe patients, SAPS-3, very elevated. It's okay. The mortality is lower than the actual mortality is lower than the expected mortality. But when we look at the less severe patients, for instance, it is more than expected. And then we can should look for instance, preventing nosocomial infections and better care in general, training, education. I think this will have a big impact.
Yeah, and what you're also saying is, fluids don't exist in a silo, right? You can debate on whether or not you have to give this patient fluids, but it's also, it's not just one organ, this patient. All the decisions that we make interact, and even the organization of your ICU may affect the outcome of the patient.
All the protocols and the winning protocols, and all together, I mean.
Yeah. So and Marlies, what about you? So I know you're very enthusiastic about, the steps that we've made in the last few years, because there were a couple of great trials with great results, and you've mentioned some of them or summarized them as the 5 landmark studies. So what are you most enthusiastic about going forward? What do you see in the next 5 years in terms of developments?
I'm enthusiastic about the fact that renal replacement therapy has been increasingly recognized as a supportive form, obviously, again, as a form of organ support in conjunction with all the other therapies which we have available. There's increasing recognition that renal replacement therapy is not provided in isolation, so it has to be adjusted to patients who may be on ECMO. The indications may be different in patients on ECMO. The indications may also be different in patients who are on mechanical ventilation as opposed to non-invasive ventilation. I think so this interaction is being recognized and needs to be explored much more. The recognition from other critical care specialties, so pulmonologists, ECMO specialists, about the importance and the role kidney renal replacement therapy can play, again, has been recognized. And there is a general appreciation that we need to understand more about the exact indications. What role does it actually have, and where can it help? And how can it support a kidney that is no longer coping on its own? And that brings me back to kidney health. So we need tools. This is appreciation that we need better tools to know whether a kidney is deteriorating and becoming more and more unhealthy or struggling, or whether the kidney is getting better and recovering, and the creatinine and urine output alone are not sufficient. So this recognition is there. We haven't got solutions, but together, I believe, between clinicians and researchers, and so we hopefully will advance this field further. So I'm quite excited about this.
Yeah, and also the biomarkers of kidney function is a key thing that you've mentioned a couple of times. All right, so we're going towards the end of this interview. So what I'm going to do is ask you to give us one final thought that even if listeners have missed all of this interview, that they still have something practical and concrete to go home with. So, Marlies, I'll go with you first. What's the message from this discussion that you would like the public to have?
My message is when you think of kidney renal replacement therapy, make sure that you ask yourself, what is the aim here? Why am I starting this? Because if you know why you're starting it may be for different reasons, to remove fluid, to remove acidic, to correct acidosis, or to remove potassium, whatever it is, there are many reasons. Ask yourself what it is, because then it makes it easier to get the timing right.
That's a very practical advice. Susanna, what's your key message?
My key message is, besides individualizing the care, it's even more personalizing the care. Because when I say personalized care, we say personalized care, it's not only about fancy or advanced hemodynamic monitoring. No, it's actually to go back to the physiology of each patient and take care of, remember the study by very simple from Foutier and using the pre-operative systolic blood pressure as an endpoint, and that's all, because we have to look at the physiology of each patient, because there are no 2 or 3 patients alike in the ICU.
So that's a message that's coming from this discussion very strongly, right? We can gather evidence from clinical trials and other laboratory research, but we have to translate it back to the individual patients, and that's your call out. Massimo, that's also something you said. Do you have a final piece of advice for the people following this session?
Yes, indeed. I guess that Susanna once again has touched 2 very important issues, which is the organization, of course, and the capabilities of personalize the therapy. For the future, I guess that we need to remind what we have learned from the pandemic, the preparedness. We need to know how to allocate the resource, when and how we have to identify the patients, and how we have to treat the patient, personalizing all the therapies that are not only mechanical ventilation, but all the rest. We are a unicum, and our approach must be holistic, cannot focus exclusively on an apparatus or a specific organ. We are a unicum, and a crosstalk of various organs, and the interactions that we often have to face are the essence for getting a better care, taking into consideration all the various aspects and the influence that our intervention may produce on the various organs and the response. And our polar star, once again, as Susanna said, is the physiology. Think in terms of physiological consequences or reasons why a patient has that specific picture, and will be always the best way to go.
Thanks, Massimo. So I think the common message from all 3 of you is think about your patient as an individual, not as an organ or several organs. Try to translate the evidence into what's best for your patient, and take into consideration the organization. That's true for the kidney, for fluids, and for ventilation. Thank you all for listening.
Thank you.
Good morning, everybody, and welcome to this last live session with interviews during this Lives 40. My name is Katia Donadello, and I work in Verona, Italy. And I have the pleasure to welcome here with us Ricard Ferrer Roca from Barcelona, Spain.
Hello, everyone.
Elisa Estensoro from La Plata, Argentina.
Hi to all.
And Giacomo Grasselli from Milan, Italy. It is a pleasure for me and us to welcome you all. And we would like to discuss all together on what has been happening during these excellent days here at Lives 40. Ricard, what are the best pieces of science that you have been dealing with us during these days?
So we have excellent discussions, discussions about guidelines, personalized therapy, which are quite complex and discussions, but and also case-based fundamentals, which is more talking about the basic things that intensivists must know. But if you talk me about science, I enjoy the poster moderator. So I invite people that are here listening us that visit the posters, because there is a lot of interesting information. Especially I was moderating 2 posters about COVID-19, very interesting, showing how critically ill patients with COVID have an increase in inflammation, worse control of the infection, and this is explaining why those patients are doing worse, and the impact that estrogens in the protection of female patients for being in a more severe disease. So we have a couple of posters covering that, and we're really very interesting.
Thank you. And do you believe that there is a stress or a greater weight for translational medicine in this sepsis-related situation?
Well, if you're talking about translational medicine, there was a symposium very interesting, because we have seen as the discovery of a new pathway of inflammation in sepsis that was discovered or described 15, 20 years ago. It was after the description, then it was assessed as a potential biomarker, then has been assessed as a potential therapeutic target, and now there are studies going on selecting patients for this treatment based in the biomarker. So the whole history from the beginning, describing the pathway, using the biomarker, designing the therapy, and now designing trials enriched by the same biomarker, I think is a fantastic history, because it reflects what we are doing with sepsis, going for try to treat all patients, and now trying to enrich the trials with a more selective group of patients. And in this symposium, really, you can see all this evolution.
Thank you. Elisa, what are your insights for vasopressor therapy in septic patients?
Well, we've been discussing in the CVF activity, and also in some other points of discussion, the Surviving Sepsis campaign guidelines, and new information that has beginning to appear about the timing of utilization of vasopressors and which vasopressors should be used as first-line ones. And I would say that the most interesting finding or discussion was about when should we start vasopressors in septic shock. And there is this change, I would say, in knowledge about using them, I would say the sooner the better. And because in a patient that is severely hypotensive, this occurs because of two motives. Patient with sepsis can be hypovolemic, either in an absolute way or a relative way, but also have profound vasoplegia. They are greatly vasodilated. So while we do have 2 cornerstones of treatment that are fluids and vasopressors, really the vasoplegia will not be reversed by fluids. And so, well, we should start with fluids, of course, but not wait too much to infuse vasopressors, because it is known also that the longer the patient stays hypotensive, the lower possibility of survival a patient has. This has been demonstrated. And of course, this with pressures under 65 millimeters of mercury, mean arterial pressure. So this time that a patient stays below this number is important. So we should act soon. That's the idea. How soon? Well, it depends on the patient. Now, of course, it starts with the 30 milliliters kilogram. Take time to be infused. And not wait until this bolus has finished to be administered, but act before. And if a patient, for example, has a very low diastolic pressure, that won't be reversed by fluids. So start with norepinephrine. That is considered the first-line therapy, the first-line drug for this. And, well, there was a great discussion about when we should ask a second vasopressor and if it is needed, no? And so there is not an agreement about in what dose or with what dose of norepinephrine we should add vasopressin, for example. Should we add it? With what dose? And the Surviving Sepsis campaign says, well, between 0.25 and 50 micrograms kilogram minute of norepinephrine, but there's no agreement in that. And there are some people that would never use a second vasopressor, but it makes sense, no? Because if we use a second vasopressor that has a different mechanism of action, we could be saying this is difficult to say, decatecholamine, no, of a patient, and with that, a decrease in the adverse effects of norepinephrine. Let's say atrial fibrillation or digital ischemia, and well, the adding vasopressor has been adding a second vasopressor, being it vasopressin, has been successful in decreasing the need of renal replacement therapies, the need of, it has decreased the percentage of atrial fibrillation, but it was not successful in decreasing digital ischemia, for example. So there's this discussion, which is very interesting about what should we be doing.
Thank you very much. We will come back to that in the next minutes. Giacomo, we've been facing 2 years of acute respiratory failure and much more. What are the key lessons that you are bringing with you during these days, the messages that you will be telling or describing to your children in the future?
Well, these days we have had a number of very insightful discussions on this. So we discussed both the organizational aspects of what happened during the pandemic and the management of the patients. So in particular, I was involved in two debates, one on the timing of intubation of COVID-19 patients and the second one on the role of ECMO in COVID-19 patients. So regarding the management of the patient before intubation, I think that what we all agreed on, and the most important message was that, we all tried non-invasive support, any form of support, like nasal high flow. In Italy, it's very popular helmet CPAP. In other countries, non-invasive ventilation with face mask. But we all acknowledge that using non-invasive respiratory support in a patient with white lungs and with severe ARDS, so or better off with acute respiratory failure not of cardiogenic origin, can be done. In some circumstances, it must be done if you have shortage of beds, of course, but it must be done carefully. So first message is that if you do this, you have to monitor your patient, because what we know is that failure is associated with mortality, and delayed intubation is associated with mortality.
And do you use a sort of alarm clock? I mean, do you
well-
decide a sort of timing that might be not be overpassed?
Well, before the pandemic, the guidelines were suggesting to monitor the patient for 1 hour, and if after 1 hour of non-invasive ventilation or CPAP or whatever, the patient does not improve, the patient should be intubated. Clearly, this was not feasible during the pandemic. But again, on the other hand, during the pandemic, we had to do things that should not become the standard, only because we showed that, well, if you are forced to, then you can do them. For example, we had to keep patients in the prone position on CPAP, 100% of FiO2, high PEEP, for hours in the emergency department. This is not good medicine. This is, I would say, war medicine, okay? So that's the first point. What we had to do during the pandemic does not mean that this is what we have, that from now on we should do.
And I believe that this is one of the most important messages of these 2 years, because otherwise we might risk to be translating what was urge, what was necessity, to what should become
Standard, which is
standard
not,
of care, which is not. Right.
of course. Second discussion was on ECMO. The role of ECMO in COVID-19 is still debated.
We'll come back on
Okay.
that. Okay. But staying on intubation, if you might choose one mean of non-invasive or initial support for an acute respiratory syndrome for COVID and non-COVID patients, and you might just have the possibility to have one with you, which one would you choose?
Yeah. I am Italian, so I am biased. For me, a patient with acute respiratory failure like ARDS, COVID or non-COVID, doesn't make a big difference, needs increase in mean airway pressure, okay? So to me, the best option would be CPAP, and helmet can be particularly helpful, for example, in this with COVID-19 patients, because it's a sealed environment, so it also reduces the contamination of the environment and the risk of nosocomial transmission of the disease. I know that helmet is not so popular, so if helmet is not available, I would go with some form of support that provides at least some centimeter of water of PEEP. I also recognize that there are studies showing that the nasal high flow reduces the risk of intubation, provides very little PEEP, but has the advantage of better tolerability, so it can be applied for longer periods. So again, I think that you should, my first choice would be helmet CPAP, but one should try to apply the support he's more familiar with, and the most important thing is that no matter what you apply, but you have to monitor the patient, and not only PF ratio or oxygen saturation, which is important, of course, but because if you have like 80% of oxygen saturation while breathing pure oxygen, we all agree that it's a very bad patient, but still there are patients who are, with acceptable, viable saturation rate. Maybe they do not appear so distressed, but they are still developing huge effort or a high respiratory drive, and that's the real point. So it's not only gas exchange, but more the distress, the increased drive, the increased work of breathing that should guide us towards intubation of these patients.
Thank you. Ricard, what are, in your opinion, the challenges that we need to be prepared of in sepsis right now?
Well, the most important challenge, I think, if we want, so we achieved many things in the last 20 years. We have reduced mortality, we have reduced the rate of ICU admission, and this has been based in improvements in the process of care, which is something that is sustained in time. part of therapy we are improving, in part because we put the focus that this is a time-dependent disease and we know that everything should be done as soon as possible, etc. So I think we achieved that in the last 20 years. For the next years, the next achievement should be to reduce the mortality in those patients that do not respond to this initial therapy, early therapy. And for that, it seems that a global approach is not useful. We have to go for a selective approach. We have to describe better the different phenotypes of septic patients, that they are diverse. They are the phenotype of endotoxic shock, the phenotype of coagulation activation, the phenotype of hyperinflammation, the phenotype of hypoinflammation. So we have to describe better these different phenotypes and selective population for specific treatments.
And don't you think that I completely agree about the need of tailoring, but don't you think that there is a sort of a black hole from the time the patient arrives and the time you manage to have recognized it? I mean, in order to cut a costume on a person, to tailor, you need to study it, him, her, and to get the results. And I find that this time window, is the most challenging one, because it is the one where we would like to be able to tailor, but we don't have the tools yet to be able to do that. So how do you think that we will be able to overcome that part? By protocolizing medicine, by generalizing, or by trying to tailor, even if we do not have the tools yet?
So you raise a very important point. So I mentioned that we have improved the process of care. So we know very well we have to do when we have the diagnosis. And the point you are mentioning is how we can reduce time to diagnosis, time to recognition, and then start to do what we know we have to do. For that, we have some scores, QSOFA, for example, 6 criteria. And for now, we don't have the ideal score, because 6 criteria have low specificity, and QSOFA have.
So you do not think that Sears died in 2016, as somebody does?
Well, systemic inflammation exists. So systemic inflammation exists. The criteria of Sears are very sensitive, are non-specific, but are very sensitive. QSOFA is more specific, but is less sensitive. So some clinicians said, I want a tool that is very sensitive. I want to detect all patients, despite that later I'm going to discard some of them because they have systemic inflammation, but the systemic inflammation is not coming from infection. So some clinicians prefer to keep the size criteria because sensitivity. The other tool we have is biomarkers. Again, we don't have the perfect biomarker. And then there are some studies that enrich the scores with biomarkers. So there is a lactate-enhanced QSOFA, procalcitonin-enhanced QSOFA, and again, there are some limitations there. So you mentioned which is going to be the future. The future probably will be in improvements in these scores, but probably in that big data analysis and artificial intelligence will help, but especially because we are keeping the patients monitorized all time, even outside of the ICU. So continuous surveillance by electronic systems, non-invasive monitoring outside of the ICU, together with new scores based in big data analysis, artificial intelligence, I think is the next step for early recognition of sepsis.
Elisa, what is your position about the infusion of norepinephrine through a peripheral access?
Well, this has changed recently, no? Because I would say that some years ago that would have been a sin. And I don't know, we discussed this in a session, but someone said that in some countries this is forbidden. No, for me it was quite a surprise. But the real thing is that there's not much evidence about this, no? So everything is comments, expert opinions, and the expert opinion in general says that norepinephrine infused by a peripheral vein, if it is, I would say, a good vein, a vein in the antecubital fossa, is perfectly tolerable without adverse effects. The risk of extravasation.
Would you choose a precise catheter to infuse it? I mean,
sorry?
Would you choose a precise catheter to infuse it?
I tell you something. That is a medical emergency when a patient arrives profoundly hypotensive. And I would use what I have, but in a vein of a great caliber, and start with the fluids and start with norepinephrine. And in the meantime, look for a better access. It has been demonstrated, at least in series, because these are all case series, that, well, the risk, it's a safe measure, you know, for some hours, of course, no, for 4 or 5 hours, and, well, it gives you time.
So you wouldn't keep the access, the norepinephrine infusion in a peripheral access for more than 12 hours?
No, not for more than 12 hours. I would say 4 or 5 hours, not more than that.
Just the time to put the central one.
Exactly.
Okay, thank you. Giacomo, I believe that during the past 2 years, there has been a sort of fashion on mechanical assistance for respiratory failure. And, but I also believe that we are finally and luckily getting to a situation of order, trying to better define people, places, expertise. What do you think?
Well, I think that if we are referring to the management of COVID-19 patients, at the beginning there was a bit of confusion, but because we didn't know the disease. Now we know much better this disease, and you know, I think that my personal opinion is that it's not too different from, let's say, classical ARDS. It's a bit, how can I say, outdated, this discussion. But I think that this is becoming the general agreement on that. And what I'm going to say goes very well with what Riccardo was saying. Again, is that, and this applies not only to patients with COVID-19, but with every patient with ARDS or even acute respiratory failure of every origin. The point is that we are trying to understand how to, I know that this word is abused, by personalize the ventilatory approach to the disease. So it's clear that if you have a patient with relatively high compliance of the respiratory system, it's probably pointless to use high levels of PEEP, but this is not because it's COVID-19, it's because it's a patient with ARDS and relatively preserved respiratory system compliance, which, by the way, exists also in non-COVID ARDS. The point is that we saw so many patients with ARDS with COVID that, I mean, we saw more patients with, let's say, relatively preserved compliance in the early phases of the disease. So and also what Riccardo was saying about phenotyping also applies to ARDS, and not only to COVID, but also to non-COVID ARDS. There are seminal studies by Caroline Kalf and the group in San Francisco that shows that with latent class analysis, at least 2 phenotypes can be identified, hypo and hyperinflammatory phenotype. These phenotypes have not only a different prognosis, but also they respond differently to different diseases. And retrospective analysis of the large negative trials made by the NIH show that, for example, higher PEEP levels are beneficial in patients with hyperinflammatory phenotype, but they damage patients with hypoinflammatory phenotype, and the same is valid for, let's say, restrictive or liberal fluid strategy, or even administration of steroids or of statins. So the idea is that ARDS, exactly as sepsis, is a syndrome that is caused by different diseases. So a disease has a specific treatment. A syndrome, there are general things that we do: fluids, vasopressors, mechanical ventilation. It's the way we apply to keep the patient alive while the therapy of the underlying disease works. Because if a patient is septic and if you don't give him antibiotics, he will die, even if you apply vasopressors very early through the correct way of administration at the correct dosages and so on. And the same is valid for ARDS. I mean, an ARDS secondary to pancreatitis is completely different from an ARDS due to COVID-19 or pneumococcal pneumonia. And so you have to know how to use the ventilator, but what you do with the ventilator is to grant a viable gas exchange and avoid further damage to the lung.
And to the other organs.
And to the other organs,
related to what the lungs need to offer.
Yeah.
Ricard, what about antibiotic stewardship? Where are we now?
Well, the situation is quite different across Europe. So the problem, just remind that antimicrobial resistance is causing more than 30,000 deaths per year in Europe, and close to 1 million years of disability in Europe. And the situation is a little bit different in countries in the south, countries in the north, and some countries in the middle with different situations. So this is a big problem. How we can manage this problem? Antimicrobial stewardship is very important. How it should be done? I think in the ICUs, of course, with the support of pharmacologists, infectologists, it's very important that intensivists take the lead in this topic, because we have some infections that only appear in the ICU. We know very well the ecology. We know very well how to diagnose, how to treat this infection, for how long time to treat this infection. So I think that the intensivists should take the lead in this topic, and every ICU needs an antimicrobial stewardship program. As I said, should be multidisciplinary with pharmacists, microbiologists, infectologists, but I think the lead of intensivists is very important.
Thank you very much. And Elisa, what is your position about epinephrine?
Well, you know, this is difficult. This is not the ideal drug, I know. But there's a fact that in some countries, I would say in low and some middle-income countries, it's the only vasopressor that exists. And this is because the WHO distributes it for free in these countries. So maybe it's the only drug they have. So I won't use I won't use it if norepinephrine is available, of course. But in these countries, maybe it's the only one option, and they should use it with some caveats, some things that they should take into account. It's a catecholamine, so it has the same effects than norepinephrine in what is related to its vasoconstriction properties, so the smooth muscle on arterial side of circulation, and also it's a venoconstrictor. It recruits microcirculation. Well, everything is okay, but it has a potent beta-1 adrenergic activity on the heart. Maybe that it's more intense than norepinephrine. So epinephrine probably causes more arrhythmia, probably increases myocardial oxygen consumption, and shouldn't be used when there is a previous cardiovascular disease in a patient that has now become septic, because, or if it is the only option, well, it should be used with very careful monitoring. And the other problem that epinephrine has is that it has metabolic effects. So it stimulates glycolysis in peripheral muscles, and so increases lactate. And this is a non-hypoxic lactate. It originates from this pharmacological effect of epinephrine, but intensivists should be careful about this and should not guide resuscitation according to lactate when you are using epinephrine. Years ago, when it was the only catecholamine available after dopamine wasn't used anymore, when we saw this was frequent, this increase of lactate. What is this? So anyway, no, at this moment of knowledge, really, nobody should be resuscitating septic patients according to lactate. That's the truth. But it's something to have into account when you're using this drug, epinephrine, if you have no other option.
And would you add it to norepinephrine?
No, I wouldn't. If I would add a second drug, I wouldn't add a drug that has the same mechanism of action. So I would use a non-adrenergic drug as a second drug, vasopressin. It's the only one we have available. Probably in the future, we'll have angiotensin, angiotensin 2, we don't know yet, or maybe other vasopressin-like drug. But for the moment, I would say the only valid option is vasopressin as a second vasoconstrictor.
Thank you. Giacomo, do you believe that in countries like Italy, we are both Italian, we should select or reduce the number of ECMO centers for VV ECMO?
Well, this is a very difficult.
I'm tricky, I admit,
No,
but just because we are both Italians, so
No.
I just...
There are different models, several models in the world. Like we go from the UK model, 6 ECMO centers now for 60 million people, to Germany, and many ECMO centers, too many ECMO centers, and even the German people admit that. So, in Italy, well, I don't know. I think that also for geographical reason of how the country is made, we have now something like 16, 17 ECMO centers for, again, 60 million people, something like that, which is, I think, a reasonable number. If you look at the suggestion from the ELSO International ECMO Network, which is a consensus of experts, they published a paper in the Blue Journal, and they said that based on the frequency of ARDS that needs ECMO according to the current indications, so I'm talking about ECMO as a rescue for refractory hypoxemia, the number of ARDS cases that you expect who have the indication of ECMO is not too high, and in order to maintain an acceptable experience of the centers, which is at least 20 VV ECMO, 20 ECMO for respiratory failure per year, you should have more or less 1 ECMO center every 2-3 million people, which in Italy makes 20 centers, which is exactly the number they are now. And we have islands, for example. So I'm not sure that we should reduce it. I'm sure that we should not increase it too much.
I agree. And do you believe that we might be more stringent, more strict with the evaluation of the quality of the expertise?
Yes, like not only for ECMO, but for more or less for everything. Like, again, in the UK, which is a model for this, every ICU must participate into an audit program. And if you do not share your data, and especially if you don't share the evaluation of the quality of what you are doing, you cannot do that job. So this is something that we really need to achieve in Italy. There is the situation, it's extremely different at regional level, as you know very well. But ECMO might be a start, but this is okay. It's the same for patients with septic shock or with ARDS. I mean, the outcome of these patients, not only ICU or hospital outcomes, but also long-term outcomes must be taken into account.
I completely agree that transparency is the basis for the future. Please, Riccardo.
Yes, I want to comment also in Giacomo's words. I fully agree with ECMO centers' concentration in cases and expertise, but I think it's important to stress that those centers need budget. Budget in the sense that those patients that are in ECMO centers do not have to phagocyte the ICU, because in some times of the pandemics, we have like more than 10 cases, which is 1/3 of the ICU dedicated to ECMO patients that has been transferred to our center. So it's so I think budget for this ECMO center is important. And the other important thing I think is equity. So it should be linked to a good transfer facility. So if we agree that we are going to have ECMO centers, we have to be able to take patients from any center and send it to the referral. And that means that if we want equity, we need a good transfer system for sending patients to the referral centers.
Absolutely, network is essential. And I believe that when you were talking about budget, not only money concept, but people concept, because we are really lacking, in my opinion, not only the number of people, but the expertise. Think about nurses. I mean, we need people who know what they are doing, and this is a matter not only of money, a cost in terms of money, but a cost in terms of time that you spend training people and keeping them with you.
And also not just the number of patients, so 20 per year, 30 per year, I think is good. Also sustained in time, because if you are just including patients in the ECMO program during the winter season, for example, then you have 6 months that you have to keep the training of the people without cases. So I think also it's important that ECMO centers are concentrated in those centers that have lung transplant programs, cardiac transplant program, or cardiac surgical activity. I mean, to keep the training the whole year, not just for some season of the year where all the activity is concentrated, at least for ECMO VB.
Thank you. Elisa, I would like to start closing this interview by selecting the key messages that you would like to send to the audience of this Lives 40 about the vasopressor support in septic patients.
What I would say first, before vasopressors, there's a question of awareness, of recognition of sepsis, and that this is a disease that needs to be, especially septic shock, treated immediately. I'm not sure that I would say, all health personnel is quite aware of this. And maybe COVID was an opportunity because the society and also people that work in hospital suddenly realized that there are urgencies, that there are emergencies. And so we could take advantage of this situation. But for me, the message would be, first, be aware of the disease, be aware that this is a disease that whose treatment depends on time. Here, time is gold, here, time is life. So people should know what is sepsis, what septic shock is, and that need to act immediately. And as soon as the diagnosis is recognized, just start with whatever you have, a peripheral line, whatever, and start with fluids. And if the patient is still hypotensive after, I would say, 20 minutes, and you can have some hints on this, because the patient has a very low systolic pressure and a very low diastolic pressure, well, you know that patient won't be responding just to fluids. So in this state of compromise, start with vasopressors soon. Remember that the longer a patient stays hypotensive, the higher the number of organ failures we ensure. So we have to act very rapidly.
Thank you. Giacomo. What are you bringing to tomorrow?
Well, what I said before. So first thing is patients with acute respiratory failure, monitor them, especially if you treat them non-invasively, monitor them to select the appropriate timing for intubation. First message. Second message, every patient is different, so we should try to tailor the mechanical ventilation setting to the pathophysiology of the disease of that single patient, and it's not too complicated, but it needs some measurements of basic mechanics, for example, and so on. Monitoring hemodynamics in patients with acute respiratory failure, it's always forgotten, but it's extremely important.
And you are a PAC supporter, right?
Pardon?
You are a PAC supporter, a pulmonary artery catheter supporter.
PAC supporter. I don't think that the monitoring method impacts on survival. It's important that you use the monitoring method that you are familiar with, so that you know what you monitor and you know what does that, for example, pulmonary artery occlusion pressure means in a patient with 20 centimeters of water of PEEP, for example. So you can use anything else you want. I mean, echo, you can use PICO, you can use whatever you like. It's important to monitor cardiac output in patients with acute respiratory failure. The reason why we use pulmonary artery catheter is because we think that monitoring, for example, pulmonary arterial pressure is important, but that's another story. Regarding ECMO and COVID-19, we still don't know exactly the role of ECMO in this disease. We've seen, we are a little bit disappointed by the increase in mortality that is reported across the different waves. For example, with the ELSO data, this is certainly has to do with patient selection for sure. Again, also with the experience of the center and the timing of the duration of mechanical ventilation before ECMO, which should include also the period on non-invasive ventilation, because patient self-inflicted lung injury exists, and we should try to avoid it whenever possible.
Thank you. Ricard, your tip messages.
Well, I think the most important thing is that keep improving your process of care for septic patients. It's amazing field. You have improvements every year. You have new antibiotics. We have learned that we have to use less fluids, to start with vasopressors before. All this evidence should be incorporated in the process of care. And this is fantastic because it's a secular trend of improving year by year, because we learn many things every year. We know that early source control is important. The less invasive source control is also very important. How the new microbiological diagnostics techniques is changing and improving the way we use antibiotics. So it's a continuous improvement of new technologies, treatments, knowledge that is coming every year. And in your department or in your hospital, you have a broader approach. You have to try to introduce all these improvements every year to improve the process of care of these patients. And for that, it's also very important to have numbers, to have indicators, and seeing how these indicators improve with the improvement you made in the process of care. I think this is the main message I have.
Thank you very much. So I'm really pleased that you joined us during this live discussion, and I really thank the speakers for having part their excellent and important opinions on these fundamental subjects. Thank you very much, and see you in Paris in October.
911 emergency.